Hey everyone, today we are going to crack the code on some of the absolute trickiest meds you'll see in nursing school and on the NCLEX, the ones for heart failure. These are high alert, high priority, and you absolutely have to know them inside and out.
Okay, let's just dive right in with a classic NCLEX style question. I'm telling you, this exact scenario trips up so many students. Your patient says they're nauseous and seeing yellow-green halos. What's the very first thing you do? Just keep that question in the back of your mind. We're going to figure out the answer together.
But before we can even talk about the medications, we have to know what we're treating, right? So let's build a quick foundation. Simply put, heart failure means the heart's pump is just failing. It can't keep up with what the body needs. Understanding this is key to understanding how the meds work. Okay, so here's the core difference you have to remember. If the left side of the heart fails, all that fluid backs up. Where? Into the lungs. You're going to hear crackles, your patient will be short of breath. They might even have that classic pink, frothy sputum. Now, if the right side fails, it backs up into the rest of the body. Think swollen legs, big old jugular veins. Just remember, L is for lungs, R is for the rest of the body. Next up, preload. Think of it just like this picture, an overflowing tank. In heart failure, the body is just overloaded with fluid, so the heart's ventricles get super stretched out. Our goal with meds like diuretics, like furosemide, is to get rid of all that extra fluid, to take some of that stretching pressure off the heart. And on the flip side, you've got afterload. Imagine trying to squeeze a water bottle, but the cap is only half screwed on. That resistance you feel? That's afterload. For a weak heart, pushing against high blood pressure is exhausting. And this is where drugs like ACE inhibitors, your lisinoprils, come in. They relax the blood vessels, lower that resistance, and make it so much easier for the heart to do its job. So, you see, it all comes down to this one crucial formula. Cardiac output is your heart rate times your stroke volume. In heart failure, that stroke volume is weak, so the whole cardiac output just drops. And that's why our patients feel so bad. Every single medication we give is all about trying to fix this one simple equation. All right, now for the main event. Let's get into our first major medication. And trust me, this is a huge topic on the NCLEX, digoxin. If there is one drug you need to know inside and out because of how risky it can be, it is this one. And I'm not kidding. This is one of the highest risk medications you will ever give a patient. It has what we call a very narrow therapeutic window, which means the line between a helpful dose and a toxic dose is razor thin. When you see digoxin on the NCLEX, your brain should just be screaming, safety, safety, safety. So what does it actually do? Well, digoxin is what we call a positive inotrope. It makes the heart muscles squeeze harder. But at the same time, it slows the heart rate down. So you get this slower but much stronger, more efficient pump, which is exactly what a failing heart needs. Now look at this. This shows you just how thin that line is between helping and harming. And here is the absolute key NCLEX takeaway. The earliest signs of toxicity are almost never cardiac. Nope, they're GI issues, nausea, vomiting, no appetite, and weird visual changes. Remember those halos from our first question? That is a textbook red alert sign of digoxin toxicity. This number, you have to burn this into your brain right now. The therapeutic range for digoxin is 0.5 to 2 nanograms per milliliter. Anything over 2 is toxic, and you need to act fast. And this is the number one trap the NCLEX will set for you when it comes to digoxin. Low potassium, or hypokalemia, makes the heart way, way more sensitive to the drug. This means your patient can become toxic even on a perfectly normal dose if their potassium level is too low. That's why you always check the labs before you give this drug. So let's use this visual as a memory anchor. Let's lock in these two non-negotiable safety checks. See the little mechanic checking the potassium levels? And that sign clearly says the heart has to be running at 60 beats per minute or more. So before you give digoxin, you check two things: the potassium level from the labs, and you take an apical pulse for 1 full minute. If that pulse is less than 60, you hold the dose. Period. No exceptions. Okay, so digoxin is for the long game, right? For chronic heart failure. But what about a patient who's in an acute crisis, the one who just got admitted to the ICU in severe heart failure? Well, for that, we need to bring out the big guns. For these emergencies, we use powerful IV drips like dobutamine. It's also a positive inotrope, but it acts super fast and super hard to just jack up that cardiac output. But because it's so potent, it's only given by IV, only for short-term use, and that patient better be on a continuous cardiac monitor. You are watching that monitor like a hawk for a fast heart rate or any funny rhythms. Okay, let's circle all the way back to where we started. But now you have the knowledge. We can solve this thing together.
Let's walk through this classic NCLEX trap. Okay, so the apical pulse is 54. That's red flag number 1, right? It's below 60. Then you see the potassium is 3.1. Whoa! Red flag number 2, your patient is hypokalemic. So, with 2 major contraindications staring you in the face, what is your priority action? You absolutely 100% hold that dose. Then, of course, you notify the provider.
We have covered a lot, so let's wrap this up with a really quick rapid-fire recap of the absolute essentials you need to walk into your exam with. Here they are, the 5 points you cannot forget about digoxin. Know the level, 0.5 to 2. Know when to hold, apical pulse less than 60. Know the risk, low potassium equals high toxicity. Know the early signs, GI upset and vision changes. And finally, know the antidote for severe toxicity, digoxin immune fab.
And, that really brings us to the real world of nursing. Knowing all these facts is one thing, but applying them with compassion, that's the whole game. Which leaves us with a final, really crucial question. How do you take all this critical safety knowledge and explain it to your patient without scaring them? That, right there, that's the art of nursing.